Good evening. Yeah, it's almost night now. Yeah. First of all, I'd like to thank all of you guys to allow us to participate in the conference. I was hearing some of the conversations and the lectures all this time. And before I do that, I want to first introduce the team. Asma on my right side. And it's very important for Asma to be here today because she is from Hyderabad. She actually grew up there, and then she's been my physician assistant for almost 15, 20 years and is involved in all the clinical trials. So it's good that you're here. Mike Lemon. Mike Lemon is our chief tech. He's actually Donald Trump's right-hand person. He's his wingman. And then you have Gabe Areta just behind. Layli, standing there. Layli's our cardiology fellow. She's outstanding, actually. Ali and Aaron are from Abbott. And on my left side is Saro. He's actually a first-year fellow. He's going to do a Mitra clip. And then you have Dusty Lloyd, who's actually going to do the case with me. Dusty Lloyd is a cardiac anesthesiologist, as well as an outstanding imager. And behind is actually my student. I also want to acknowledge some people in the room, Tom, Sophia, and also Craig and Pedro from MedInbox, who's transferring through MedInbox. So with that, can I just show the case? Start.
Morning,
next slide.
Saibal. Lovely to see you.
Yeah, good morning.
Please go ahead.
Sai, I saw you there. I saw you, and I also heard your comment about the 5 years from now. 5 years from now, we'll be still teaching people how to do Mitra clip. And you'll be teaching people. Okay. I heard the comment. So, I heard that comment. 81-year-old lady.
Saibal,
sorry,
Saibal, I'm here too. Just watch out, okay?
Eberhard is in the audience.
Namaste, everyone. Adab. It's nice to be here today presenting this case for you. This is an 81-year-old female who has had increasing shortness of breath over the last 1 year. And she recently was hospitalized with CHF, and she's on maximal tolerated GDMT. She has a past medical history of a prior stroke, but she has no neurologic deficits from that. She's got a prior LAD stent, which was put in March 2012. She's insulin-dependent diabetes. She has a CRT device, which was implanted 2020, and she's on oral anticoagulation for atrial fibrillation. No history of smoking. She's a widow. She lives in a senior living facility, and she uses a walker for ambulation. And you can see her medications there. She's on good GDMT, as I said, sacubitril, valsartan. She's on metoprolol, Ozempic, rivaroxaban, and atorvastatin and torsemide for diuretic therapy. And now we'll go over to echo and see some echo images.
Go to the next slide. So this is just the baseline which we did today. There was a transthoracic. You can see there's actually bilateral enlargement, moderate LV dysfunction, and severe functional MR. And actually, what I couldn't show is Layli, our cardiology fellow, is outstanding. She actually did a global longitudinal strain. And what she showed, I wish you could show the pictures of a classical base being more hypokinetic and the apex being slightly spared, which is actually a characteristic degree of amyloid. So we potentially think that she may be in a case of amyloid. So you can see the bilateral enlargement, the low voltages, and severe functional MR. So we plan to do a Mitra clip for this treatment, but we do agree that based on the findings that you said, Layli, we may actually also work her up for amyloid. And we've seen that.
Next slide.
I think that's the last slide.
There's one.
And that's the T. You can see it's a wide jet. And the valve area is not very large. It's only 3.9 to 4 square centimeters. So, Dusty, do you want to show some pictures?
Yeah, these are some pictures I got earlier, about 15 minutes ago.
Yeah, can you transfer to echo now? Echo and fluoro, yes. Can you go to echo, please, Pedro? Yes, good. Make it a two-screen thing, like fluoro and echo. Yes. There you can see, make the echo larger. Yes, that's great. So you can see that it's a very wide jet, severe MR, and you can see one ground was on there. You can see how close the papillary muscles are to the valve. You agree with it, Dusty?
Yes.
And that
short distance.
A very short distance. And do you want to show
The left upper pulmonary vein, reversal systolic flow in the right upper pulmonary vein.
Okay, and you want to show a short axis, a 3D end phase. And that's the 3D end phase. And the calculated valve area, Dusty, what did you get?
I think we got 3.8.
Yeah, we got 3.8 to 4.
Yeah.
So what do you think we should do?
Saibal, there are so many questions here that I think will be pivotal to the discussion of this case. You have a borderline valve area. You have what looks like a mixture of both degenerative and functional, because that AML is not moving as well as it should, in my opinion. We would love to hear actually what you think is the best way forward for this case. From the way I look at it, you have one shot, you have a wide jet, you probably have only space for one clip. Even then, you risk a significant gradient. Saibal, the floor is yours.
Yes. So, there's a reason why I showed you the papillary muscles. Yes. And you can see the papillary muscles are very close in the bicommissural view, very close to the leaflet. So there are very few technologies which will allow you to do a TMBR. So even if I wanted to do a TMBR, I don't think I can do it. So the only option I'm left with is trying to do a mitral clip. So anyway, since did any comments from anybody else?
Saibal, Ramesh here. So actually, it just happened this last Monday. I saw a similar patient with atrial functional MR, and we thought similar on as you did, or your echocardiographer did. We did find that as amyloid. So once you diagnose with amyloid, do you actually give some time for the treatment, or actually proceed with what is the timeline for TEER versus actually treatment for the amyloid?
I think we haven't worked it up. We suggested based on what I just told you. I wish I could show you the global longitudinal strain with a classical, it's called a cherry on white appearance, but we will work her up. We will continue to work her up and we will treat her, but I don't know whether this is going to go away. But MR is quite dynamic. It's very severe at some points. It gets mild at some times. I'm going to see what it happens. Like, let's do a clip and see what happens.
Yeah.
So we could always take it out.
Yeah, you're right. Because it's a white jet, you probably want to do a XDW. That's what I would look at it.
I was thinking of an XDW, but we are concerned the posterior leaflet is only measuring 9 millimeters. Mm-hmm. And so we are actually going to try an NTW. Yeah, okay. And if we think that, if not, we go to an XDW.
But one thing we're going to have to start, discussing and talking about in this type of cases is that, unlike, again, TAVR, in which we look at the anatomy and we say, maybe this is the valve we're going to use. Mitral disease is a very complex, disease that actually goes beyond the anatomy, and you have to take into consideration longevity of the patient, myocardial baseline performance. I mean, like in a patient with a low ejection fraction with possibility of amyloid disease, I don't really think that actually replacement is a good idea at all. Number one, because the myocardium is not going to react very well to the implant, because the ejection fraction may deteriorate even faster, and you may actually have thrombogenicity issues to start with. If you put that with the high papillary muscles that actually only few technologies can really deploy well with a high papillary muscle, this is actually is the best option for transcatheter repair without any doubt.
Thank you.
So, Juan, I actually liked what you said. In fact, you agree that most of the summaries, if there was an amyloid case, they would actually exclude the patient, right?
No,
in most of the studies?
Absolutely.
Yeah. So even though we haven't proven it, but we are going to try an XT, would most people try an XTW?
Yeah, just because the gap, I think, is larger in this patient, and you can try NTW, but I don't know whether you'll be able to get a good grasp. But that's what I was thinking. So that was my rationale.
We'll take one. We will take one. We prepped the clip, and we actually are going down. Can you make fluoro and echo big only, so that they only see echo and fluoro? Can you see the LA pressure? You can see it's ranging between 18 to 22, prominent V wave. But I'm going to focus mainly on the clip and make echo large. Always make echo large, Pedro. Fluoro small. Yes. Okay, good. So what we're going to do is I'm going down on the valve. I've actually moved it slightly more down. And I'm trying to go in the middle. And he's trying to show me the middle. That's a very nice image. Dusty's an outstanding imager. He was actually trained by Burkhardt from Washington. I like that trajectory, right? I think the trajectory looks good.
Spot on.
I'm going to open the clip at this point. Let me just make it coaxial as much as I can. And then I'm just going to go. I see Dr. Chandrasekhar's on the panel.
Morning, Saibal. Morning.
Yeah, good morning. Do you agree with my assessment of potential amyloid?
Saibal, I think you should have become an echocardiographer, man.
Yeah, I wanted to. It's a better lifestyle, at least.
I'm not quite sure about that, though. I'm not
He's
quite
too
sure
hyper
anymore.
for that.
No. No, it's fine.
Okay, so let's do a 3D end phase. So we're going to do a 3D end phase and just see how we've oriented the clip. So we're quite off by a lot, so let's get it a little bit more. So clockwise is like this, hold it like that. And you see how the span of the clip is, that makes me encouraging that this size will be okay.
Yep.
You know what I'm saying?
Absolutely, the XTW would have been too large for this anatomy, I think.
Yeah, for this annulus, right? So I think for this annulus, this is reasonable. So I'm just going to transmit the torque. And I think this looks good. My plan is to put the clip right at this position. Do you agree with that, Dusty and Dr. Chandrasekhar?
Put the color there, Saibal. Put the color there.
Put color there.
Yep, looks
Yeah, I
good.
think so. Yeah, it's perfect. I agree with you. Yeah.
Okay. So I'm just seeing the grippers. Can you see the grippers? Just go to explain once. Okay, so let's put the color off for a second. And yeah, so I'm just going to see which grippers what. So this is anterior. So the blue is posterior. The dot is anterior. Okay. So what's happened? So Ali's whispering and telling me, should we give a little bit of plus? I think it should be okay, right? I think we can try this. We can try a little bit of plus. It's okay. A little bit of plus is okay. I agree with you. And then bring it down a little bit. Okay. So I think we went a little bit medial. So I'm just going to take off a little bit of M. And let's put the color here. I'm actually going to move a little bit more lateral, somewhere here. Let me try. I think I'm going to go right in the middle and see what happens, right? We have air pressures. We have everything. So let's see what happens somewhere in this spot. So I'm going to close the clip. And I'm actually going to go down in the ventricle. You can go into explain function. And then we go, right? Okay, and I'm just going to go in just below. And you can see, as you know, you can see the papillary muscle is very close.
Yeah.
I mean, you see, it's such a high papillary muscle. And this would have been a real challenge for any of the TMBR platforms. And so now I'm opening it on a V. And I'm actually going to come more closer to the clip. And let's look at 3D. And you can see it's slightly off, right?
Yeah.
So we should counterclockwise a clear. Dusty, you agree with that?
Yes, counterclock.
Yeah. So let's go down.
Yep, looking better.
I like that. Now let's go to BICOM LBOT. And let's see where the color jet is, because put color there on.
You're right.
I actually like this position.
Yeah.
Right, guys, do you agree with that?
Yeah, looks perfect.
I think it's a reasonable position to
Yeah,
try.
looks good.
Okay, good. And that's where you can put the clippers down. So you get color off. And both the leaflets are on. Looks nice. And I'm going to drop both the grippers. And you see both the grips are bouncing. So then I always check 3D again before closing the clip. And you see the orientation looks, I think, almost perfect, right?
Yeah.
It should be oriented slightly counterclockwise.
That's the only thing I would say was counterclock.
Yeah, decrease the gain a little bit. Yeah, let's go a little bit counterclockwise. Decrease your gain. Go back to, I think it's okay though.
Looks great.
Yeah, it looks pretty
Saibal.
good there, yeah.
Looks good.
Huh?
Looks great.
You like it?
Yeah, it looks
Okay, all right. So if, Sai says great, I'm going to take it. What does Ramesh say? Ramesh wanted an XTW into two. Okay, so
Yeah.
let's go down and let's close, explain that.
I think the length of the leaflet clip arms look good on this one, and I take
Yeah,
it
yeah.
back that NTW is doing well. So let's close it and see. Maybe I don't know whether we need to be a little bit lateral. We see that already left atrial
Yes.
pressure went up, so XTW would have made it definitely worse.
So let's look at LA pressure as it goes down. I'm closing the clip. Asma, you want to close slowly? Start closing slowly, very slowly. Close. Do you see how the LA pressure went down?
Yes.
Oh, sorry. Oh, sorry. Let me just open it up a little bit. Sorry. I go to 60 and then lock the, and then close it a little bit tight. And so the LA pressure came down dramatically, right?
Yeah,
Did you guys see that?
At least by 10 points, yeah.
Yep. So let's close it more and then let's have a look at the MR assessment. So at
Ready?
least LA pressure wise, it looks good. So you see, going more laterally would not have helped because the jet is actually more medial, correct?
Right.
Correct.
Okay. So I think that's a good position. Now let's look at gradients.
Moment of truth.
So the gradient is not too bad. Ramesh, I also was thinking of XTW, but when I measured the leaflet length
Yeah.
and the annulus diameter, I thought this would be. So it's 3, it's not too bad.
Baseline was 1.
1. And now let's do pulmonary veins.
Yeah, no, initially in one view it looked like that the gap is more, but in these images doesn't look that the coaptation gap is that bad.
So she was almost reversed or blunted, and actually it's staying like that almost, right?
Yeah.
Can you get a better signal? Okay.
Yeah, look at that, right?
Yep. So it was reversed when we started the case. Sorry we didn't show it to you.
We showed it.
No, we did. We
saw
saw
it.
that the systolic
We saw
reversal
that?
was there, yes.
Yeah.
Now it is
Okay.
systolic dominant. And
No, it's not dominant. It's blunted.
It's blunted,
Blunted,
yes.
It's severely blunted. So the question is, should we leave this here and put another clip? Let's look at where the jets are from.
You want me to get it left upper again?
Yeah, you can do left upper.
Same, yeah. Blunted.
Yeah, it's blunted now.
All right.
Okay. And the LA pressure is 24, but it's because, and the blood pressure is 134 by 74. So that's nice. And then let's look at it, explain. So let's look at each of those jets. So the two options that we can do is 3D and face that. We can put a one clip, explain. So Ramesh, you agree that this is right in the middle, right?
yeah, this is right in the middle. I mean, the question is, it looks still, on color flow, it still looks mild, MR, on either side. So if you want to do it, whether you want to move this clip first to medial and then put a second clip lateral, or do you just want to get one of the, leave this here and put another clip medial to it, is my question.
Okay, so let's do one thing. Let's look at the explain those color jets. So the P's are big. It looks like medial, right?
Mm-hmm.
So explain the medial jet.
Saibal,
Yes.
just a small comment. She's got a 3.9 valve area. You've got such a beautiful
Yes.
result. Gradient is 3. Do you want to even consider, I mean, for the benefit of the house, Do you want to even consider
Yeah.
just leaving this here and leaving her with this and optimizing GDMT?
No.
Instead of the second clip?
I'm thinking of that. I was thinking about that.
Yeah.
Laterally, let's see the lateral jet.
I feel terrible moving this clip.
Right. This
Yeah,
is
it's a
excellent.
good grasp.
So this is, we were talking, what I mentioned in my talk, right, that this is the operator's paradox in mitral tear, in which, if you stop here, you get a good result and you're safe and you accept a little bit of residual MR. If you actually go more aggressive, you need to put more clips, you end up actually with a higher gradients. And, in a patient like this, especially with such a great anatomical and technical result, if you optimize therapy, you're going to be able to decrease that MR even more.
Right.
And you have a non-compliant LA. She's not going to tolerate a higher gradient. She's 84. But just for the benefit of the house, you can see how, Saibal, of course, is a master. He makes everything look easy. But you can see how graceful this procedure is. There was absolutely no hurry. He took his time, which was about 5 seconds, went exactly coaxial, opened the clip up, looked at the orientation above, looked at it below, let the leaflets fall on it, and there's nothing chasing you. He checked all his data points, then he put the grippers down. He still didn't close the clip because these 84-year-old leaflets are like muslin cloth, and you don't want to damage them unless you really have to. So he took his time, he looked at the orientation, and in case you're wondering why he was so dogmatic about having it perfectly coaxial to the plane of coaptation, because if it's slightly twisted left or right, it distorts the valve and they don't do well on the long term. So it was just such beautiful images. Credit to your echocardiographer and such excellent maneuvering, Saibal. It was a pleasure to watch as usual. I'm going to give the floor back to you. I had to mention it for the house.
Thank you, Dusty. Thank you very much, Sai. Sai, I think we were oriented correctly, right? I don't think we had an orientation issue, right?
No, it was perfect.
I don't think there was.
It was perfect and
Yeah.
central, and the one clip procedure it's quite decrease in the MR jet, and another clip will increase the gradients. It will be a detrimental.
So there's two options that I have. I think I should leave it here. I agree with you. We've got a very good grasp, right? We should leave it. Dusty, you agree with that? But do you mind if I just deploy it and then try an NT beside it?
Yeah. So the panel actually thinks leave this alone and optimize guideline-directed medical therapy. So either way, I think deploy it, and maybe you said the blood pressure went up, right, actually? After.
Blood pressure is 138/77.
So there's room for GDMT, that's what they were saying. So it's up to you,
Yes,
Saibal.
yes.
You can
Saibal,
try it, but you can take it out as well,
Saibal, we can do what you've always told me to do. Deploy the clip, look at the pressures, assess everything, and then take a call.
Yeah, we can do we can do MPR and measure the valve areas. So let's do that. Let's just deploy this clip, right? So I'm just going to deploy the clip. So do you want to open it? Asma, do you want to do that? Or Mike, do you want to do it? Mike, try to open it. So Asma sped. It was thrilled to come. Okay, come here. Good. And then just do it, close it. Let the positive side and neutral. I think this is neutral. So we're going to deploy it, okay? So take this out. The clip looks quite closed as I can see. Okay, good. Turn it around. Oh, yeah. The best way to do it is actually not like that. Best is to take it just counterclockwise about.
You have 30 more minutes.
Now separate. Huh?
You have 30 more minutes. So you can... I don't know, I feel the MR might slightly increase, so you have 30 more minutes. If you want to take another NT, as far as I'm concerned, I
would try another NT. Do the floss, you're good. I'm going to try an NT anyway, if that's okay with you guys.
Yeah, that's why I said, please entertain us.
Okay. It looks quite close, the clip. I always have this superstition of closing the clip once again and then now trying to open it again to neutral. So the clip hasn't moved at all. So that's nice. Then positive side neutral. Then take this bayonet out. So we just, okay, good. And now try to open this out 5 times. 5 times. Go. Yeah, counterclockwise. Keep rotating. Good. Okay, keep coming more. Good. Now 8 times this one. Counterclockwise 8 times. 8. Okay, good. Pull it out. Okay, good. Put this back. All right, the clip got deployed. Actually, the MR group less now.
Yep.
Now we'll understand a little better. Let me take the clip out. It'll take me a couple of minutes to just take it out. So let me do this. Let me do that. Is the clip in? Do you have enough clip inside? A guide inside? Can I look at the guide?
Yeah, hold on.
Just show me the guide. Okay, there's enough guide. And then let's get that, this thing, the suction. So we deployed the clip. And you know, this is as Sai mentioned, there are very few procedures which you can do so relaxed without any changes of blood pressure, with any arrhythmias, nothing, right? You know, you do a TAVR, you do a PCI, all of them have hemodynamic consequences when you're doing them. This one doesn't seem to have anything. That's a nice tissue bridge, right?
Great.
Looks very nice.
Okay, let's do color now. And can you show it from dual view?
Jet on the right side has disappeared.
So we were right in the middle. We took care of A2P2. The question is, should we try one? The valve area is not very big. Okay. I'm almost thinking of not doing anything. All right. Let's look at the 2D color, which is a little bit more exaggerated. What do you think, Dr. Chandrasekhar? Do you think I should try one?
I think it looks pretty good, and I think you can put another one and try and see whether
on the medial side.
Medial side, yeah. Adjoining the.
Can you get an NT?
Yeah.
Can you get an NT?
There, yeah.
All right, we're going to try an NT. Can you explain the medial jet?
There it is.
Yeah. I think we can. Let's try to put one very close, and hopefully the gradient doesn't go up.
Sure.
But you did see how the LA pressure went down when I. What are you doing?
Yeah, from what it was, actually, this is an excellent result. And, you know, I think
NT.
you can try it, but you can also leave it. I think probably if you're starting off, if you're Saibal, you can try it. If other people probably can just leave it. What?
So most of the people would say just leave it alone, right?
Yeah, that's what
I got a mean gradient of 2 now.
I think
So he's getting a mean gradient of 2.
I think in a patient.
Mean gradient is 2. Mean gradient is 2, Saibal. You should try. Put an NT.
Okay. And on the medial side, right?
Yep. If it was 4, I would have left it alone, but it's 2
No.
after you
4 I
release.
would not. 4 I would not do it for sure.
See, by and
So he's
large,
trying to do an MPR and see whether he can assess the valve area, which I think is reasonable. But I think what we've done is that we've got the main body of, and one more thing that we should discuss, that, you know, Mitra clip is not just an edge-to-edge repair. It is a type of annuloplasty also, because it actually stabilizes the anteroposterior diameter. And so we know that with changes of blood pressure, it will not change too much.
I think Saibal, the better part of the Valerie is probably it's a good clinical result. I think she's on optimum medical management, and I think there's nothing wrong in just leaving up.
Yeah, Lily, can you do me a favor? Can you show your phone with the pictures? I want to show it to the audience, what you did. Can you show it in large? Can you bring it here? Can somebody do me a favor? Pedro, can you focus a camera on Lily's camera? I'm sorry we couldn't put it on the PowerPoint. Is this camera working?
Yes.
Okay. Yeah, can you see this? Can you see this more larger? No.
No.
Yeah, go this camera right here. Go closer. Yeah, 233, 2000 of heparin. Can you see the global strain?
Yeah. Yep.
And you see it's minus 14, and you can see what is impressive is that the middle, the apex is actually slightly normal, and the base is abnormal, and that's the characteristic. What is it called? The cherry on top appearance. This is a very characteristic of amyloid, where the bases get more affected than the apex. And that's why we were just doing echo. And this is a good thing for teaching's sake. There are three things which bothered me: biatrial enlargement, EF which is moderately reduced, and this global strain pattern. And as what Juan Granada mentioned very nicely, he said amyloid is actually a tricky thing for replacement because the base of the heart gets very affected by amyloid more than the apex. And now when you put a TMBR in, you actually immobilize the base. It actually makes things even worse. So that's why you rightly said that you have to be very careful when you're doing amyloid cases for any form of therapy. Am I right about that, what you said, Juan?
No, absolutely. I mean, what people don't realize is most of the mechanisms of anchoring in TMVR affect the base of the ventricle. And especially in cases like this, you could predict a significant impact on myocardial performance by putting a TMVR device.
Okay, so I'm just going to go in with the second clip. Dusty, are you measuring it? Okay, you can measure those two, yeah. So Dusty is measuring those areas separately by MPR. Dusty is an outstanding imager. The problem is that on the weekends, he prefers surfing. And he's not happy coming here at this time of the day.
Yeah, you're making them work hard in the night on the weekend.
Yeah, yep. And his manager, Tanya's over there. She's upset because we are in STEMI diversion now.
Oh.
Tanya's very upset. She's looking at me and looking at... Tanya, are you still upset?
You have to take her out for dinner later.
Oh no, she's like shouting at me, screaming at me.
Yeah. So Dr. Raghu and Dr. Chandramukhi, I'm sorry, you can join us as the chair and panelist. Right? Please come.
I wrote clips. So we are advancing the second clip. Okay. So you want to do this? So just do 1/4 turn. Go. So Sai is, keep going. He's a first year fellow, but he's really impressed in interventional. He started with MitraClip training and then TAVR, and then he's going to do diagnostic angiograms. Keep good turning, more. Keep going, more. Go more. Pull 1/4 turn. Good. Yep. I do a little bit more. So I use fluoro a lot when I do them. Keep going. Just quick, just fast. Good. Okay, good. All right, can I see bicom? So I'm just going to come a little bit here.
So okay, for the benefit of the house, he has to come under the clip in fluoro because he wants to get this clip in medially. So what Saibal is doing now is he's lining it all up nice and coaxial in the LA. So there's the least amount of movement when an interaction with the clip when he's just crossing.
So I'm going to open the clip now. I'm nice and parallel to the clip. 3D end face. You know, I actually rotate the clip before coming down because I can make the two clips parallel almost just by fluoro.
Mm-hmm. I saw that.
Right? You agree with that? So I'm just going to go down. I think this orientation looks good, right?
It looks perfect.
Okay.
Maybe
so let's go like that.
Saibal. Maybe just a tad clockwise.
I did that. Okay, good. I think it'll go a little bit more clockwise when I go inside. So do you want to decrease the ventilator speed?
So what Saibal is doing is when he goes lung down, the clip will sail medially. So that way, once he's lined it up, he doesn't have to do anything else. He can go lung down and then it'll give him a little space to go in.
Just to give you an idea, I mean, I'm getting second thoughts of putting a clip. His LA pressure is now 15 and the blood pressure is 145 by 62. So you can see how the heart remodels with this clip, okay? So now let's go to Biocom LVOT. He's decreasing the tidal volume so that there's less movement when I go down. And I'm just going to track the grippers. Can you put this on the arms? So the blue is posterior, the dot is anterior. All right, I'm going to go very close to that clip. So what I'm going to do is, when we do second clip procedures, fluoro is quite helpful. You agree with that? So that's exactly what I'm doing. I'm trying to use fluoro. I want to come more closer. I actually want to go even closer to the clip than possible to put color on. Oh boy, the MR is getting better now. The lateral jet's very small, so I think we should go very close to that first clip. I'm going a little bit here, taking off a little bit of gain. I'm going very, very close to that first clip. I want to go even more closer. You see how close I'm coming? Mm-hmm. I'm being as close as possible. So I just went right below.
Beautiful.
And then I'm going to open the clip.
Amazing. Saibal, I love watching you.
Thank you. So you agree that it's close, and we're just going to see 3D end face.
Can you show the echo now? Yeah,
seeing
thank
the
you. We can see it
now. The orientation looks okay, right?
Maybe counter.
I think it's okay. Yeah. If I open the clip a little bit more, you'll be able to see it. Yeah, its orientation is perfect, right? It's up and down.
Yep.
Right, Ali? Ali's not happy.
It's 12:05. That's why he's not happy.
Yeah, 12:05, right? Okay. All right, we can go a little bit clockwise. How about that? And let's go back to Biocom LVOT. And let's try to see whether I can see that. You see the leaflets? How nice they are on it? Mm-hmm. So we can do 3D now and just see the leaf. And as Sai said, I take my time. I orient it before I drop the grippers. Decrease the gain. Okay, so I think I can go a little bit of counterclockwise, right?
Yep.
Right?
Yes. Mm-hmm.
Okay. Let's go to grippers. 15 pressure. Both the leaflets are, there's a nice posterior leaflet in. I'm going to take as much as posterior as I can. I think there's enough anterior too. Yep, there's enough anterior. So I want to go as much as I can, take as much posterior as I can. And then I'm going to drop the grippers. And the posterior is down, anterior is down. Let's see 3D end face again. And then we'll close it.
Wow,
oh my God.
Big bridge.
Okay, nice swing. Can you see can you decrease the gain? Okay, now start closing, Asma. Hold this. And no, let's go to, very slowly. Can you go back to, yeah, that's good. Start closing very closely. And we never try to, there's no rush to close it. So we let the leaflet go down.
Lock at 60?
Top. Yeah, we locked already. We actually locked a little bit earlier. And then go down, Asma, a little bit more. Okay, go down a little bit more. You ready? A little bit more. Go. You can go more. I like to close it tight. So there was no, LR pressure is 14. Did you guys see the LR pressure? Can you show the LR pressure, sorry? Pedro?
Yeah,
can you see the LR pressure now, guys? Mm-hmm. Look at the MR now.
Pretty good, actually, very good.
The medial jet is almost gone. The blood pressure is 128 by 61. There's a small lateral jet. And I think we should just deploy this, right? You want to measure gradient?
Gradient.
Yeah.
Yeah. I mean, by doing so close, I think the gradient will still be maybe less than 3 in my opinion.
Yeah. Yep. So, Dr. Chandrasekhar,
Yeah.
I was thinking of changing career and becoming an echocardiographer.
No, I'm just kidding. See, listen, we need everybody, and I think since you've been doing this for a long time, you've acquired the imaging skills that you...
3 millimeters. Do you see that?
Yeah,
it's
3.
very good.
Now let's see 3D. Let's look at pulmonary vein. Oh, look at that. That looks beautiful. I think, Dusty, you're getting the hang of it finally. All right, so let's do the pulmonary vein. Where's Gabe? Is he gone to the restroom? No, we have one of our techs. Whenever things go really bad, he says, "Can I go to the guest room?" And I think he's gone to the restroom. Oh my God. So that's the red blow. And this is very nice. You see how the diastolic flow has reduced in amplitude? And the systolic is
It's
right?
increased, yeah.
Right? And that's a characteristic of this thing. So let's do the other vein. And that's a nice, good sign. You see that? And let's do color there. Look at that.
Increased systolic amplitude.
Right? So the systolic amplitude you get, but there's a decrease in diastolic amplitude. Right. Am I right there, Dr. Chandrasekhar? Am I talking sense or I'm just talking nonsense?
No. I think you're talking pretty... I think you make sense. Don't worry. I think you're good, man.
And can you look at the LA pressure now, large screen? It's 15 now. We started with 20, 24, 23, and now it's 15. All right, so I think we should, and the V wave is down, so I think it was right to have deployed the second clip. Juan, do you agree with that? And also, I want to show you something fluoroscopically. Can you look at the grade MR? It's much less now. There's just a medial commissural jet, which is from the commissures, which we wouldn't have touched anyway, right? And the lateral jet is very small. So if you look at fluoroscopy, do you see that the lower clip is more atrial than the clip up above? Can you see that? And that usually indicates I've got more tissue inside it because there's more tissue graft. So I think we should just deploy this. I don't think we should waste any more time. Let's go and deploy this. Okay. All right. Yeah. So let me get a view. So usually I try to get a view where you can see the clip very well. Let me find a nice LEO angle. Okay. 1 minute. Okay. Now, close it tight. Close it. Yeah, close it once again. Yeah. Yeah, I think the MR is really mild now, right?
Yeah, I agree.
Okay. Okay, now try to open it and you do the thing. So you see that she's opening it. Good. Very good. And you see the clip is not opening at all. That's a good sign. Good. And then go to positive side or neutral. That's it. Yeah. Good. All right. Alan? Good. Now open that. So I do want to acknowledge something else when we do a case. We have Ali from Abbott. She's been working with you for many, many years. They really play a very big role in this procedure. You probably can't hear her voice now because she doesn't have a microphone. There are 2 of them here. And I'm going to tell that to all the members of the audience that this procedure is one where you really need to listen to them because they actually know this procedure very well. Do you guys agree with that?
Well, there's no question because see, they have several important role to play. One, they see the case from the beginning, and also they know the product, and they've also seen many cases and many complications, many mishaps, why and what not. So their knowledge repository is quite enormous. There's no question about it. I think they do play a significant role.
So, Saibal, from the technological point of view,
yes,
technology development point of view, every single time I see people put in a second clip, it makes me think that there is an opportunity for innovation and development of clips that actually have more capability to adapt to the anatomical variability that actually you see in these cases. Do you agree with that?
Yes. Yes, actually, Juan, I have been telling Abbott, I think you got more pull than me, you should tell them. One of the biggest problems, you saw how I came with this clip very close, right? And when I got it up, it's okay. But if I had to take it out, the grippers interact with the leaflets, and it actually makes it sometimes difficult to come out. So I agree with you that for a second clip procedure, they have to modify it to make it safer to easily go in, and if it doesn't work, come out. Is that what you're saying, Juan, right?
Saibal, let me ask you a question.
Yes.
Instead of Mitra clip, if you had used Pascal, because the
Could I have used Pascal in this case?
No, Pascal, the wider paddles, you think that you would have required the second clip?
So it's very interesting. Like the Pascal, there's two devices, Pascal Ace and Pascal P10. It's interesting that even the company is moving away from P10 and asking us to do more P-Ace. And P-Ace is actually 6 millimeters, which is equal to a wider clip. So I don't feel that there's too much of a difference between the two technologies. So I think it would be okay with either. I'm not trying to say say one thing's better than the other, but I think they're reasonably good technologies. They do the same thing. They're just a tool. And for me, I've had more experience with MitraClip, even though I was one of the first people to do Pascal. But I'm not going to say anything negative or anything. But all I can tell you is that one thing people has to know, that the Pascal is the best form of complement is imitation, correct? And the Pascal is an imitation of MitraClip. It is gripping two leaflets between two metal plates. In fact, that is the patent of Farrell & Powell, is gripping. She's unfortunate she's not alive to have seen where her technology has gone to, but that was her patent. Anyway, going to that, I think I agree with you. There is another advantage of Pascal over clip, which I think is that, as Juan said, that when you try to advance Pascal into the valve, and you want to take it out, you can elongate the Pascal. And actually, when you elongate the Pascal, it's easier to come out. So that, I think, is one definite advantage. I do want you to focus on the LA pressure right now. The blood pressure is 128/56, and the LA pressure is 14. And so the MR has reduced, and so I think it was the right thing. Thank you for your advice to have gone ahead and done the second clip.
Yeah, thank you. I think the other limitation of P10 also with Pascal is imaging, right? And that's one of the reasons that we always have a tough time imaging that device.
Exactly.
Yeah.
So Dr. Chandrasekhar, that is one classical, what he said is absolutely right. Because it's got a little bit more fabric, sometimes imaging becomes a challenge. But before I end, we have finished our case away in time.
Yeah.
And actually we only have 5 minutes. I want Dusty to show a couple of last images, because Dusty is almost falling asleep. I don't want him to fall asleep.
And your groin closure is a ProGlide or a Matra suture?
A single per close.
Yeah.
And so measure the LA pressure final. I'm pulling out the guide, and I just want to show the final result to people. Yeah, you saw what it was like before, and you can see what it looks like now.
Yeah. Can you look, for the audience who have just walked in probably, can you show the pre and post?
Yes.
Sure.
Dusty, can you show the bad MR before and then post? That'll be really good. Yeah.
That'll be great. Thank you.
All right. So we just pulled out the LA pressure, and I want to show this to you. Juan, this is for you guys. Does shunt have, that's the MR. Can you see that?
Yeah.
Here's pre.
So that's pre.
Look at that jet.
And reversal of systolic flow in the left upper pulmonary vein.
Yeah. Wonderful result.
And then let's show the final. And look, that's the final.
Yeah.
Right. And I want to show something else. Can you show the LA pressure now? Can you show LA pressure, Pedro? LA pressure, Pedro. Yes. Can you make epidural large? Look at this. I pulled out the guide catheter.
Yeah.
And look at the left atrial pressure. It's 8. So on 12 to 14, the reason why I'm showing this is that people are aware of this new data of shunts in HFrEF and HFpEF patients. And in one of the studies, and one, you can make a comment about this, it actually showed a benefit. And this is a patient with HFrEF. And you see, as soon as I brought out the guiding catheter, there's obviously a 4 millimeter hole. The left atrial pressure is now 8. And so we went from 23 to 15 to 8. So maybe shunts do work in some patients. So that's the final result. And I want to thank Srinivas for allowing me to show this case to all of you guys. And the panel was obviously extremely esteemed, very difficult people to deal with, but who really appreciate. I have a lot of respect for all of you, especially I've had a great experience working with Sai in Apollo, and I'd rather be in India right now. And I also learned a lot from Dr. Chandrasekhar. And before I end, I would like to acknowledge people again. Tanya, I want to thank you for allowing us to do this case. And Sammy, thank you for arranging everything.
Yep.
I would like to attend Pedro and Craig from MedInbox. We transmitted this whole case through a Zoom system, which is inbuilt into the hospital, and we can go live. So this is actually a new system that we allowed. I also want to thank all the staff who have come here at this late age on a Saturday, when you could have been drunk by now, but instead of you're here. Or you could have been in a Trump rally. You could have been in a Trump rally. You're not here for, okay? Yes. And I also want to thank Gabe that you didn't go to the restroom, but you need the most. And Dusty, thank you very much for those amazing images. Dusty, those are the fun. Dusty Lloyd is an outstanding anesthesiologist, and I actually agree that if you're a good cardiac anesthesiologist and you can image, I think it's okay. You don't need a separate imager if necessary. Even though I know there are some exceptions, but usually in a mitral clip case, it's okay. Not maybe in a TMBR.
No, he did an excellent job. I don't think there's any question about it. I think the way the images are shown is perfect.
Thank you. Saibal,
thank you very much.
From Dr. Eberhard Grube.
Saibal, that was masterful, and maybe we can discuss, I have a question looking at the case back when you started.
Yes.
There was a little bit of a split jet, and I'm just wondering, I mean, obviously it was masterful, as Sai said, and you couldn't have done any better, but, looking for a less experienced operator, thinking that you would not be able to do with one clip, would you consider or would you advise for a less experienced to start a little bit more lateral and then move to medial instead of navigating very, very close, very skillful, 2 clips side by side? Would that be a consideration?
Usually, Eberhard, when I decide to do 2 clips, I often go the first clip either slightly lateral or slightly medial to the midline. In this case, I chose 1 clip because all of us as a group thought that this case would be as a smaller valve area and we would have to do it with 1 clip. That's the reason why I did middle.
Yeah.
But otherwise, if the valve area was larger, I would have done what you said. I would have gone slightly medial or slightly lateral. Actually, I would have gone slightly medial.
Yeah.
And then the first clip's there and then gone side lateral.
Okay, thank you very much.
And by the way, Eberhard, I just want to repeat that MitraClip is a very good Band-Aid.
That's what I was. That's why I warned you. You were just starting that I'm in the audience here, so I'm glad you didn't say it.
That's right. And as you also know, that Band-Aid is the major income for Johnson & Johnson. So Band-Aids work.
Well, thanks very much. I can see you in a good mood.
Yeah.
Why don't you just
on Saturday
stop
night
and get drunk?
Saibal, thanks
and
to
once
you
again,
and
I would
your
like
wonderful
to tell
team.
the organize.
Yes. Thanks to Tanya and her team. Thank you very much for entertaining us for the past 1 hour with a wonderful result on MitraClip. 2 NTs placed right next to each other, and reduction of severe MR to trace of 1+ MR. Thank you.
Thank you. Bye, guys.
Saibal, bye. Thank you. Thank
you.
you for all you have
Thank
done
you.
for India's MitraClip journey, Saibal.
Thank you. Thank you.